التليفون تبعي خليه بعيد عني، ما يعني انا راح اقعد هون. Good afternoon. Today we will talk about a new subject, which is rheumatic fever, in particular acute rheumatic fever. And one point from the beginning, you have to differentiate between rheumatic fever and rheumatoid arthritis. Two different categories. We will have a lecture, inshallah, قريبا, about rheumatoid arthritis, which is different, completely different from rheumatic fever. We are going to talk to define rheumatic fever, epidemiology, diagnosis, complication, treatment. These are the clinical sides of the rheumatic fever. Acute rheumatic fever, incidence and pathogenesis. This disease is common in children between 5 and 15 years of age. We have to note. But I am saying common. I am not saying only. Right? The most common cause of acute the rheumatic fever is the most common cause of acquired heart diseases. You know, there are genetic heart diseases and acquired. Rheumatic fever affects the heart, in particular the valves. So if you get damage in the heart, there is a good possibility it has been caused by rheumatic fever. Why rheumatic fever occurs? It is a delayed hypersensitivity reaction, immune-mediated hypersensitivity. If the patient develop or the child develop acute streptococcal beta hemolytic group A streptococcus, which is called Streptococcus pyogenes, the immune system get confused between the microorganism forming antibodies against it or cell-mediated immunity and the cardiac myosin, the material of the muscles of the heart, and the sacrolimal membrane surrounding the heart muscles. So the antibody that attack the streptococcus attack at the same time the muscles and their membranes. So there is a cross reaction antigenically between Streptococcus pyogene and the muscle structure. And this will result in inflammation of the three layers of the heart: endocardium, myocardium, and pericardium, which is called pancarditis. When the three layers inflame, they are called pancarditis. What else with the heart? The joints, the skin, the central nervous system will be also affected. You can add it. Okay? Now, there will be fibrinoid degeneration in connective tissue. connective tissue in between the tissues, of course. So this will be also affected. In the heart, there are nodules which are called Aschoff nodules. These are the Aschoff nodules. These are microscopic nodules seen in patients with rheumatic fever. These are pathognomonic of rheumatic fever. What is the meaning of pathognomonic? It is certainly diagnostic, 100%. Composed of foci of T lymphocyte, few plasma cells, and activated macrophages. A clinical features of rheumatic fever is multi-system disorder. I said heart, joints, skin, central nervous system. So multi-system usually follow streptococcal pharyngitis, acute streptococcal pharyngitis within 2 to 3 weeks. Why 2 to 3 weeks? Until the immune system mount the immune response. For example, antibody formation, which takes such a time, then the antibodies will affect the heart structure. The patient will have fever, anorexia, lethargia, and joint pain, and varieties of symptoms. We will discuss them gradually. 75% of the patient have arthritis, التهاب المفاصل, and I'm going to speak about the characteristic of this arthritis subsequently. The condition may be associated with rash, carditis, neurological changes, as I said, and we are going to categorize them gradually. The diagnosis depends on the revised Jones criteria. حكينا بالendocarditis Duke's criteria. Today we are speaking about revised Jones criteria. Here, 2 major or more to diagnose, or 1 major and 2 minor criteria will be diagnostic. In a moment, I will show you what are the major criteria and what are the minor criteria. The blood culture. You may ask me, pharyngitis and the microorganism will go to the blood. A blood culture will be only positive in 25% of the cases. So not that. 1/4 of the cases will be a blood culture positive. These patients, because they have got streptococcal infection, antistreptolysin O titer, antibody titer, will be also increased. In all patients? No, not in all patients. And I will talk about this. The patient may develop chorea and pericarditis, inflammation of the 3 layers. Chorea is abnormal movements. I will discuss it also with the major criteria. Abnormal movement of the hands, face, may be presented for the first time with chorea and carditis. The patient is unaware. I have seen tens of people from villages. They come with rheumatic heart disease, different pathology in the valves, and they are not aware. You can see people having chorea, especially girls, all right? And they don't know that they have been infected or have acute rheumatic fever previously. So the first presentation will be with chorea and pericarditis, without infection evidence previously about the condition. What are the major criteria? Carditis, polyarthritis, not single, polyarthritis, chorea, erythema marginatum, and subcutaneous nodules. These are the major criteria, and I'm going to discuss them one by one. The minor criteria: fever, arthralgia. Just 1 second, and I will be with you. تفضل. شكرا، غلبناك. شكرا. The minor criteria: fever, arthralgia. Arthralgia is not arthritis. It's painful joint. Arthritis is an inflammation of the joints, right? You have to be aware about the difference. A previous rheumatic fever may reoccur. يعني مو واحد من صار عنده rheumatic fever خلاص بعد ما يصير عنده. It may reoccur, and this point we have to consider it in the prevention process that I am going to speak about it later. Raise ESR and CRP, inflammatory markers. Leukocytosis, again. First degree AV block in the heart. Rarely second degree block, atrioventricular block. So first degree, which does not necessitate any treatment, as you know. There are supporting evidence. The patient may have a previous preceding streptococcal infection, sore throat, something, tonsillitis, or a scarlet fever, anti-streptolysin O titer may be increased, supporting evidence, or other types of antibodies against streptococci may also support the diagnosis. So you can see this figure, the clinical features of rheumatic fever. Those which are written in bold letter are the major. Those which are written in thin letter are the minor criteria. So the major criteria: carditis. You can see carditis may be manifested as dyspnea, syncope, pericarditis, Caricombs murmur. I will talk about Caricombs murmur in a moment. Okay, I will explain it to you. Aortic or mitral regurgitation. The same thing that I described with endocarditis. Why regurgitation? It is in the acute stage. So regurgitation will occur. Fibrosis require months to occur, and that will result in stenosis. So first of all, we will have mitral or aortic regurgitation and heart block. Subcutaneous nodules, we will see them over the bones or tendons. Erythema marginatum is another criteria. Flitting, polyarthritis, and arthralgia. What is the meaning of a flitting? Migratory. It migrates, usually the large joints. The large joints are involved in rheumatic fever. This is versus what? This is versus rheumatoid arthritis. The small joints are involved. Small joints are involved. This is not absolutely cut like that in rheumatoid arthritis. Maybe large joints involved, but mainly small joints. And prior sore throat, Sydenham's chorea, which is called sometimes St. Vitus dance. There is ceremony, religious ceremony called St. vitus dance. So the patient will move his hand, his face, his expression as if they are dancing. تفضل. تعال فوت.
شو اسمه احنا عندنا محاضرة جراحة. أنا محاضرة عند الدكتور لوحده أنس.
أخذنا بس 5 دقائق أو 6 دقائق.
كحجنا بيجي فيه 15 مرة. طب أنا جاي من جد.
أدمن.
عند دكتور
أنس.
دكتور
أنا مسكتني إشارة أزمة بدي إيش أعمل لك؟ 5 دقائق أقل أنا تأخرت. طب مش حرام؟ طب أنا يعني أنا جرش بيتي وداومت بمستشفى جرش وجيت من جرش لإربد رجعني وحطني.
لو ما عندي محاضرة كان يعني تصرفت يعني بس بدكم تتحملوا أو تروحوا تستسمحوا.
حكينا له
قدام.
والله ما بقدر على شيء لأن بالمحاضرة أنا.
حكى لنا الدكتور شادي، حكى لنا توازي.
الدكتور شادي موجود؟
حكى لنا يروح على الدكتور زي أنه إبراهيم. يعني إذا بتحكي للدكتور شادي بس إنه يروح عليه أو هيك يستسمح.
ما بيقدر. مين السي ار تبعكم؟ موجود معه. هلا بقول هلا. مر لي على دكتور أنا تقول له دكتور زين يستسمحك وإذا بيقدر. متعصب. هي هاي المشكلة.
اللي حكى لي دكتور شادي شوف الدكتور زين.
والله ما بقدر أتصرف الآن لأن أنا بالمحاضرة
صح.
يعني فصعبة.
تأخير كلها 4 دقائق دكتور. فوق 50 طالب فوق 50 طالب ما بديش افوتهم برا. 4 دقائق
يعني اللي في برا طلاب.
هاي مثلا جاي من جرش. هاي جاي من جرش. هاي جاي عشان تحضر المحاضرة.
حطنا غياب كمان
يعني
عشان 4 دقائق.
على كل حال يعني أنا لو بيدي إشي أعمله لكان عملته هسه. أنا متأسف المحاضرة اللي ما أقدر أقطعها أكثر، أو أنت تقدر تستسمعه من لساني تقول له دكتور زين يترجاك يعني. تمام؟ يلا إن شاء الله. الله يعافيكم يعني. Carditis, we said that, and sent vitus dance. So let us take them one by one. Carditis. Pericarditis involves the 3 surrounding layers as we described them. The incidence of carditis in children, young children, by the age of 3 years, it occurs in 90% of the cases. In patients who are adolescent, and you know what's the meaning of adolescent, only 30% of the patients will be affected with carditis. The patient, if develop a breathlessness, it may indicate heart failure, pericardial effusion. These can cause, as we have seen in the figure, this may indicate heart failure or pericarditis. Also, the patient may have palpitation or chest pain, pericarditis, pancreatitis, tachycardia, cardiac enlargement, murmurs. Now we come to the murmurs, which is the most important part in the clinical examination. We said that rheumatic fever is a good cause, a common cause for damage to the heart, acquired damage. First of all, soft systolic murmur. Soft systolic murmur, it comes with mitral regurgitation, which is very common. لكون regurgitation, it means the valves are apart. Regurgitation. So the first heart sound, which results from a closure of the mitral and the tricuspid valve, so the first heart sound will decrease لأنه متباعدين الكسبس، يعني ما تصير هذه الحركة. There is another thing in fever due to hyperdynamic circulation. Also there is soft systolic murmur in fever. and the patient have fever. But what is the difference between them? In fever, there is no decrease in the first heart sound. In mitral regurgitation, there is decrease in the first heart sound. This requires experience, of course, and the training, good training. When you hear murmurs, you will learn that. Soft mid-diastolic, which is called caricombs, اللي حكينا قبل شوي. Caricombs. This is soft mid-diastolic, may be due to valvulitis, inflammation of the valves, and nodules on the valves. All right? And there is no increase in the S1 sound. This is versus what? In mitral stenosis, there is mid-diastolic murmur. In mitral stenosis, due to the narrowing of the valve, so in the closure of the mitral valve, the first heart sound will increase. While in caricombs, there is no increase in the first heart sound. The last one, aortic regurgitation, which is early diastolic murmur, which is seen in 50% of the cases. This is the British cardiologist, Cary Combs, who reported that type of murmur and named after him. So Cary Combs is the name of cardiologist, a British cardiologist. When you examine, just to review it for you, I take the chance to review it for you. When you examine the mitral valve, you put the patient on left lateral position حتى يكون الهارت قريب من الستيثوسكوب تبعك, and you use the bell of the stethoscope. When you examine the aortic valve, you make the patient sit on the bed and leaning forward, and then you put the diaphragm of the stethoscope in the aortic area and at the end of the sternum to look for the aortic regurgitation. Other valves rarely involved. Tricuspid valve may be involved, pulmonary valve may be involved, but rarely, not as common as mitral and aortic valve. Pericarditis may be manifested with chest pain, pericardial friction rub. Pericarditis, I have seen patients, you may suspect with them myocardial infarction, and then it returned to be pericarditis, not infarction. And there are a lot of investigation we have to do it to differentiate between them. ECG, you may get ST changes, T wave changes. We will see that in the coming slides. Conduct defect, we said first degree doesn't cause anything, but if it is second degree, which is a rare condition, there may be a syncope with the patient. زميلك شوية تنبهه عزيزي يعني خليك شوي صاحي معي. خليك صاحي معي لأن المحاضرة لها حرمة. Now, the second major criteria is arthritis, is the most common major manifestation. We say 75% of the cases of rheumatic fever. يعني أنا كل المرضى اللي شفتهم أكثر من 75% بيجي لك in the acute stage, of course I am talking. مو زي المثل اللي أعطيناه سابقا على الكوريا. بيجي لك with arthritis, flitting migratory arthritis, jumping, large joints, elbow, knee, wrist, and it's migrating between the joints. So most common, this occurs when the antibody titer that we have spoken again, streptococci is high, which cross-react with the heart and joints, right? And يعني أنا أحكي لكم شغلة. في أنتيجين تبع الستريبتوكوكس وفي أنتي بوديز. immune complexes تتكون. في damage directly by the antibody، في damage by the immune complexes. في مكانات في الجسم deep areas we call them at which the immune complexes will be deposited. One of the areas joints. شو كمان؟ kidney yes. يعني احنا ما حكيناها لسه بس ممكن associated with kidney damage due to immune complexes. Glomerulonephritis is due to immune complexes due to what? To rheumatic fever. What else? In the skin, at the junction between the dermis and epidermis, there will be deposition of immune complexes. هذه مناطق رخوة بالجسم. In the brain, also deposition of the immune complexes, which will result in Sydenham's chorea. يعني أنت لو تفهم هالميكانيزم هذه, of course you will know what are the clinical pictures of the disease. It's painful asymmetrical, وهذه أيضا أحد الاختلافات مع rheumatoid arthritis. Rheumatoid arthritis symmetrical, right and left. بالacute rheumatic fever asymmetrical, and the joints are painful and migratory. Large joints, knees, ankle, elbow, wrist. In a quick succession, the joints will be red, swollen, and tender. Red, swollen, and tender. And ممكن واحد يسألني دكتور قديش يبقى بالجوينت ويحول؟ It could be 1 day, could be 4 weeks. Usually days. 2, 3 days, 4 days. And then it will migrate to other joint. حتى ممكن يقول لك المريض دكتور والله شوف طاب هذا الجوينت وراح هو migratory يعني. اوكي؟ أنا مرات استعمل في الطريقة هي علاجية تشخيص. If you give large dose of aspirin within 24 hours only, 24 hours, you will get a dramatic response of the arthritis. If not, it is not rheumatic fever. It's not acute rheumatic fever. You give large dose of aspirin, راح أقول لكم قديش نعطي aspirin. If there is a dramatic response, it is acute rheumatic fever. If no response, it's not. The diagnosis is wrong. You have to find another diagnosis. Good test and simple test. Skin lesion, erythema marginatum, which occurs in less than 5% of patients. You can see it. This is the erythema marginatum. It occurs on the trunk, extremities, but not on the face. If you see it on the face, it is not erythema marginatum. Good point. Excluding. Okay, so these are red macule, fade at the center, شفتوها. In the center, pale in color, and mainly on the trunk and proximal extremity, not on the face. Right? And the red ring and margin, sometimes they coalesce with each other. يعني ترتبط لأنه كل وحدة تقريبا 0.5 to 2 centimeters. Sometimes you see big lesions. These are different lesions coalesce together. ارتبطت مع بعضها. And these are firm, painless on the extensor surface of bones and tendons. Usually they appear in more than 3 weeks after the appearance of the condition of the clinical manifestation. نستفاد منها بالتشخيص؟ لا. عبر التشخيص خلاص أنا شخصت 3 weeks. It is used just to confirm the diagnosis. That this is, we were right in the diagnosis if they occur. So confirmation of the diagnosis. Other manifestation, you may get pleurisy, pleural effusion, pneumonia with the condition. You can see it fade in the center. Some of them coalesce together, like this one. Sydenham's chorea, which I said sometimes described as St. Vitus dance, this is late neurological manifestation, appear after 3 months. الموضوع خلصان. But these are late complications due deposition of immune complexes, mainly in the basal ganglia. When other signs and symptoms almost disappear, لأن بعد 3 أشهر العلامات الأخرى تقريبا كن اختفت يعني ما باقية. In up 1/3 of the patient, it occurs. The Sydenham's chorea, in about 30-35% of the cases, they develop Sydenham's chorea if they are not treated. If they are not treated. Commonly seen in females. And these females have very characteristic. The first case which I have seen when I was a student in the 5th year medical college, right? Females, they are liable, emotionally liable. شو معنات emotionally liable? The patient in a moment laugh, تضحك. In a moment cries. So emotional liability. This is called emotional liability. Also, they show purposeless, involuntary, coriform movements of the hand, of the face, and feet, and their speech is explosive. كأنما كلام انفجاري. Explosive speech. Recovery usually occurs within a few months, and 1/4 of these patients with Sydenham's chorea develop a chronic rheumatic valve disease. And I will speak about a chronic rheumatic valve disease at the end of the lecture. What sort of investigation you have to do? We have mentioned some of them, but inflammatory markers, ESR, CRP, just to monitor the progress of the disease. If you give a treatment and then these markers decrease gradually, it means there is response. If they stay and become higher, it means there is no response. The diagnosis may be wrong. You may take a throat swab. We said from pharyngitis, from tonsillitis. يعني عادة نشوف مرات الأطباء الكلينيكال وأنا واحد منهم يسأل الطلاب مثلا يقول هذا المريض عند Mitral Stenosis شو السبب؟ راح جابوا acute rheumatic fever احتمال صاير عنده وصار عنده Mitral Stenosis. يسألك شو سبب شو الميكرو اورجانيزم اللي سببت الاكيوت روماتيك فيفر هذه. كثير من الحالات الطلاب عابرين صايرين سنة 6 الميكروبيولوجي يقول لك والله احتمال، يقول لك دكتور زين ما مدرسكم ميكروبيولوجي كويس. ترى common question ها، very common question هذا. ف you have to know that these conditions you may check them by taking a throat swab culture, which is positive in 10 to 25% of the cases. I said 1/5 SOT, anti-streptolysin O titer, normal. That is to say in 20% of the cases. يعني مو كلهم ال ASOT عالي. 20% may be normal. فهي الكرايتيريا واحد تجمع الثانية. Echocardiogram. Echo. You see mitral regurgitation, aortic regurgitation, pericardial effusion. This may be seen with echo. وليش ما stenosis؟ حكينا ما في fibrosis لسه، لاحقا راح يجينا الستينوسيس. Investigation that to be done, we said the inflammatory markers, leukocytosis, ESR, CRP, evidence of a preceding streptococcal infection. شو ال preceding streptococcal infection؟ throat swab group A, beta hemolytic streptococci. Also you have to take it from the family members and contact. يعني مو فقط المريض، احتمال بقية العائلة أيضا حاملين. And you have to deal with that condition. Anti-streptolysin O titer. بالأطفال تعرفون معرضين للسور ثروت. فنعتبر الكت اوف فاليو لحد 300 يونت نورمال. in adult لحد 200 نورمال. أكثر من 200 مرات نشوفها بالآلاف، يعني مو 100 و200 و300، بالآلاف نشوفها. أوكي؟ الأنتي ستريبتولايسين أو تايتر. فأكثر من 200 بالأدلت يونت، أكثر من 300 بالتشيلدرن يعتبر abnormal. Evidence of carditis, take chest x-ray, cardiomegaly, pulmonary congestion. ECG first degree heart block, rarely second degree heart block. You may see features of pericarditis, you may see T-wave inversion, reduction in QRS complex. شو معناته reduction؟ ده تشوف هذا pleural effusion، pericardial effusion sorry pericardial effusion. فالconduction مال electricity will be different. Okay, so you can see some of the QRS complex good size, some others are very small, low magnitude. This is an indication of what? Of pericardial effusion. Pericarditis, although this is not our subject today, but I just to remind you with your cardiology. أكيد أخذتوه أنتم بالكارديولوجي. Just to remind you that pericarditis, you may get PR segment depression and concave ST elevation. شوفوا concave، ال ST elevation concave. This is an indication of pericarditis. Management single dose. تصوروا يعني، لأنه streptococcus pyogen very sensitive للبنسلين. وهذا فد إشي we are lucky sensitive للبنسلين. So single dose of benzyl penicillin 1.2 million intramuscularly, it will end the infection. If you don't have benzyl penicillin, you can use oral phenoxymethyl penicillin. شو هو البنسلين؟ البنزايل penicillin، البنسلين البلوري very painful. يعني انت من تعطيه عندنا فد قاعده بالعراق هاي موجوده، من يجيك واحد قروي اذا الابره ما توجعه هذه مش كويسه. فالبنزال penicillin is very painful. الفينوكسي ميثايل penicillin is the weakest penicillin. اسمه penicillin V بالمستشفى اسمه penicillin V. Very weak. You can give 200 milligram 6 hourly for 10 days. بينما البنزال penicillin single dose. Alternative إذا البيشنت عنده allergy للبنسلين you can use erythromycin and you can use cephalosporin. Although I don't recommend, there is overlap in hypersensitivity. قد يكون مو allergy, قد يكون شيء آخر يعني. If penicillin allergy, I don't advise you to give cephalosporin. 15% there is overlap in hypersensitivity between the two. The most important item of the treatment bed rest. شوف نفس المريض كويس بعد يومين 3 4 يقول لك والله عندي شغلة بالسوق انزل. No. Complete bed rest. This is very important to follow, and this is guided by what? By symptom, temperature, leukocyte count, of course, and ESR. Cardiac failure may occur due to the damage of the valves, and you have to give a treatment. This is another thing. And you may get also AV block. Usually we said first degree doesn't require, but if the block is more severe, you may require to put pacemaker. And you know the pacemakers. Aspirin relieve the symptoms of arthritis within 24 hours. Dramatic response, but you have to give large doses. Look, starting dose 60 milligram per kilogram body weight per day in 6 doses. يعني divided لأنه الكمية كبيرة. أنت أضرب واحد وزنه 40 كيلو في 60 والحبة 300 ملغرام. شوف كم حبة تطلع. كثير. And then you can increase it in adult to 100 milligram per kilogram body weight. You may use up to 12 grams per day. كثير يعني. I have used myself 10 grams. Up to 12 in one patient, in a few patients. You can, aspirin is safe drug. But sometimes due to high doses, the patient may get mild toxic effect. Nausea, tinnitus, deafness, tinnitus معناتها طنين الإذن. يجي لك المريض يقول لك دكتور عندي طنين صار بإذني من وراه. يقول له بس تخلص العلاج راح يروح هذا ما في مشكلة. More serious, the patient may develop vomiting, tachypnea, and acidosis. You know, aspirin is acetyl salicylic acid. So acidosis, okay? Continue your treatment until the ESR has fallen and then gradually taper. Corticosteroid can produce more rapid response. Steroid. So, but you have to be careful about the side effects of the corticosteroid. We don't recommend to use corticosteroid except in exceptional cases. Indicated, for example, in carditis with severe arthritis, you use the corticosteroid. The long benefit of the corticosteroid is questionable. Aspirin will be very good. Exceptional, we use corticosteroids. How much we give corticosteroid? For example, if you choose a prednisolone, 1 to 2 milligram per kilogram per body weight in divided doses until you continue until the ESR is normal and then taper. the dose. As you know, corticosteroid cannot be cut abruptly. Secondary prevention. حكيت بالبداية streptococcal infection may reoccur and rheumatic fever may reoccur. So you have to prevent recurrence of the condition. ممكن ينصاب المريض، ينصاب مرة ومرتين وثلاث وأربعة وخمسة. Okay? So in that case, even streptococcal infection تعلموها هيك على هامش المحاضرة، في genetic predisposition وعملنا دراسات عليها. في genetic predisposition. شوف الطفل ممكن ينصاب عدة مرات بالسنة بstreptococcal infection. So there is genetic elements for it. So susceptible for further attack, and you need to use long-term prophylaxis. What is long-term prophylaxis? Benzathine, penicillin 1.2 million unit intramuscular monthly. شو اسمها هذه البنزاثين البنسلين؟ هاي الأبرة الشهرية، المرضى بيسموها الأبرة الشهرية، أبرة زيتية. شو معناتها زيتية؟ depot effect, long effect. It can cover 3 to 4 weeks for the patient. فكل شهر ياخذ له أبرة. بنزاثين penicillin. Don't be confused between benzyl penicillin and benzathine penicillin. Two different categories. Okay? Or you can use again phenoxymethyl penicillin, which is the penicillin V, 200 milligram BID twice daily. Alternative, sulfadiazine erythromycin. Recurrence usually very rare after the age of 21 years. يعني الشخص ما يصير عمره 21 سنة خلاص يعني ما يكفي، يكفي أن تعطيه prophylaxis. But if that patient had attack in the last 5 years, you have to extend the regimen for more years. Okay? Example, there are certain occupations or living areas, crowded, damp, رطبة. Teachers, المعلمة والمعلمة in contact with the small children, and the small children يوميا فد عدد منهم مصابين بالstreptococcal infection and sore throat and so forth. So these teachers are prone to develop recurrent rheumatic fever. So you can extend it after the age of 21. If the patient has or have residual heart disease, you can extend it 10 years more or up to the age of 40 years. يبقى ياخذ البروفيلاكسس لحد 40 سنة. And you have to know prophylaxis does not protect against infective endocarditis. لولا الناس اللي مصابين بالهارت دامج بالكاردايتس أو بالفالفولار disease, we said they are more prone to develop what? Infective endocarditis. Good. So the cover of prophylaxis against rheumatic fever does not protect against infective endocarditis. Now we come to the chronic rheumatic heart disease. هسه damage و regurgitation. الآن راح يصير عندي fibrosis. تمام؟ In chronic 50% of rheumatic fever with carditis develop a chronic rheumatic heart disease. كثير 50%. 2/3 of them 2/3 هذه ال50 اللي تحولوا للكرونيك 2/3 of them are women. In only 50% of these chronic rheumatic heart disease had history of rheumatic fever or chorea. Many of them are not aware. يعني ممكن يجي لك مريض خاصة اللي أنا شفت من القرى الفيليجز فارمرز رعاة بيجي لك أنواع الميرمرز تسمع هو مش عارف إنه شو صاير بيه. a lot of patients, more than 50% may not tell you that they had history previously. Mitral valve is affected in 90% of the cases. It's the most common valve affected. Aortic valve come next, and then tricuspid, pulmonary. Isolated mitral stenosis, it may be seen isolated, only mitral, in 25%. Both mitral stenosis and mitral regurgitation may be seen in 40% of the cases. Valve disease may be completely asymptomatic, and the patient is not aware until it comes with complication and fulminant manifestation like heart failure. Pathology, what's the pathology of a chronic rheumatic heart disease? Is the progressive fibrosis. Now, the heart valve predominantly affected, and if the pericardium and myocardium are involved, the patient may have heart failure and conduction defect. All right? And mitral stenosis with or without regurgitation, حكينا mid-diastolic murmur بالmitral stenosis. With what? Increased first heart sound. And stenosis, okay? This is versus CARICOMS, هيدا عيدة اللي شرحنا عليها ما في increase in the first heart sound. Aortic tricuspid valve may be seen as stenosis or regurgitation, and the patient will have altered hemodynamics due to the valve damage. Lastly, this caricature shows you the major criteria and the minor criteria. Jane's, J, polyarthritis, A, carditis, nodules, subcutaneous nodules, E, erythema marginatum, and Sydenham's chorea, Sandvitas dance. You can see the hand. The minor criteria: arthralgia, prolonged PR interval, fever, elevated inflammatory markers. And lastly, I leave you with this video. It is a very interesting video. I recommend you to see that video. نعم.
الانتي انفلاماتوري دوز من الاسبرين كونترا انديكيتد بالتشايلد ايج ما عدا بحاله الكواساكي ديزيز، فهل بنعاملهم معامله الكواساكي بالروماتيك فيفر ونعطيهم اسبرين؟
سؤال جيد. ده يسالني الاسبرين ما يعطى للاطفال. ليش؟ مين يعرف السبب؟ شو يسبب؟
accumulation في ماده بتسببها accumulation بالليفر وبالبرين.
Okay. Okay. So the which is called Rye syndrome. Okay? Rye syndrome. الاسبرين ما يعطى للاطفال خلاص. Two exception زي ما حكى الكوازاكي والاكيوت روماتيك فيبر. Two exceptions. لأنه مضار الأسبرين أقل بكثير من مضار الأكيوت روماتيك فيبر. نتلاحظ كيف؟ فعندنا رخصة فيها. Good question. في other question؟ نعم. إيش؟ لا إذا تعالج من البداية سيدنهام سكوريا ما تحصل. بس إذا untreated والimmune complexes تكثر deposited in the brain, you will get Sydenham scoria. But with good treatment, it will be prevented. If you give the treatment early. ايش؟ نعم. لا دقيقة، سمعيني سؤالك كويس.
البنزايل بنسلين حكينا نعطيهم سنجل دوز بس بعدين لازم نضل وقت ريست ما
until inflammatory markers back to normal, symptoms disappear. هذه الجايد انت تبعك. واحد السي ار بي تبعه 100. اكيد انا لسه عارف السي ار بي نورمال اقل من 6. بعض المختبرات اقل من 4. واحد عنده سي ار بي 100. انت لازم تستمر بالعلاج.
يعني بعطيه سنجل شوت من التريتمنت وظل اندر اوبزرفيشن لحد ما
نستمر على الاسبرين.
كومباينيشن ثيرابي ولا الانتي مع الاسبرين صح؟ يعني ياخذهم الاثنين مع بعض.
صحيح سنجل دوز وخلص.
تمام هذا بالنسبه
خلصت الاسبرين تستمر.
طب دكتور سؤال اخر الريثرومايسين اذا كان عنده سنسيتيفيتي للمسالين ايش الدوز اللي بعطيها ولا
الدوز يعتمد على الايج اوف البيشنت. انت لو تراجع الانتي بايوتيك تبعك الايج عاده له فاكتور عدد 25 ملي جرام per كيلوغرام per year. اوكي؟ حكينا انه البنزايل بنسلين single dose. But other antibiotics you can extend it like penicillin B up to 10 days. 10 days.